Hi, everyone. Welcome to another Facebook Live broadcast with Medstar Health. My name is Sarah Ridenauer, and today I'm joined by Medstar Health spine surgeon, Dr. Fahim Sandhu.
My name is Sarah Ridenauer, and today I'm joined by Medstar Health spine.
Had a little bit of an echo there. Sorry about that. I'm joined by Medstar Health spine surgeon, Dr. Fahim Sandhu, and hopefully by Dr. Bobby Calantar later. And today we'll be discussing minimally invasive spine surgery. We'll cover topics such as the spine's anatomy, when you should see a doctor, what makes surgery necessary, and how to preserve your movement. We've got lots to discuss, so stick around, give us a like to let us know you're watching, share this broadcast with your friends, and if you have any questions for our experts, please leave them in the comments below. Dr. Sandhu, thank you for joining us today. We really appreciate you taking time out of your day to join us and answer our questions. Before we get started with the questions, would you mind telling us a little bit about yourself and the work you do for Medstar?
Sure. Thanks, Sarah. Thanks for the invite to be here. So I'm a neurosurgeon. I'm also the director of spine surgery and co-director of the minimally invasive Center for Spine Surgery at Georgetown Medstar Hospital. And, we really are focused on treating all aspects of spinal pathology and, try to use the latest technologies and methods to do that in a less invasive way if we can. And, fortunately, most problems are now amenable to minimally invasive techniques. There's some that still would be preferentially treated in a more traditional open manner, but many of the things that we commonly encounter in terms of problems for patients, we can treat using minimally invasive techniques.
Great. Well, thank you again for being here. Let's get into the questions. We'll start off with this. Can you tell us a little bit about the spine surgery program at Medstar Health?
Sure. We have a large number of surgeons, both orthopedic and neurosurgeons that focus on treatment of spinal disorders. And sometimes we'll work in collaboration. Usually each surgeon works individually, treating a patient. But we do use a multidisciplinary approach, especially for treatment of tumors. We have research aspects where we're doing clinical trials for new devices and also focused on clinical outcomes for some of the procedures and things we do. We use navigation and robotics as part of our program, and we have an enhanced recovery after surgery, or ERAS, program that really helps facilitate recovery and pain control after surgeries, which can be daunting for patients after spinal surgery.
Right. Well, thank you for explaining that. And hi, Dr. Calantar. Thanks for joining us.
Hey guys, how are you?
Good. How are you doing?
Doing well, doing well.
Great. So before we get back into the questions, Dr. Calantar, would you introduce yourself and tell the viewers a little bit about the work that you do for Medstar?
Sure. My name is Bobby Calantar. I'm an orthopedic spine surgeon. I've been at Medstar for 12 years. I'm the chief of orthopedic spine at the Medstar Orthopedic Institute across the Washington region, and we work really closely with our neurosurgical colleagues. We've had a lot of joint ventures. I just caught the end of what Dr. Sandhu was mentioning with the ERAS protocol and things like that, where we really can enhance the whole operative and non-operative experience in many cases for patients. So it's been pretty exciting. Great.
Well, we appreciate you being here. Getting back into the questions, Dr. Sandhu, can you talk about the difference between an orthopedic spine surgeon and a neurospine surgeon?
Sure. I think historically there were kind of differences, and if you look back 25 years ago, orthopedic spine surgeons focused more on the fusion and treatment of the bone issues with the spine, and neurosurgeons worked around the spinal cord and nerves. Those boundaries have kind of blurred with time, and nowadays both neurosurgeons and orthopedic surgeons do very similar things in the treatment of the spine. So, as neurosurgeons, we learn to place instrumentation and do bone grafting and fusion, and I think the orthopedic surgeons have become more comfortable working around the spinal cord and nerves. There are some things that I think neurosurgeons do that orthopedic surgeons don't do, such as treatment of tumors inside the spinal cord or anything intradural. But I think otherwise, we're very similar in terms of what we do. And most of us here have fellowship training or subspecialty training in spine surgery, particularly whether it's from the neurosurgical side or the orthopedic side. So our interests and focus are very aligned, I think.
Okay, thanks for explaining that. So Dr. Calantar, could you explain the anatomy of the spine?
Yeah, I mean, it's a pretty amazing structure. We have cervical vertebrae, which is what our neck is made up of. Those are the bones that support our neck, and we have 7 of those. We have thoracic vertebrae, which are our mid-back kind of rib cage vertebrae that are the bones that support that mid-back portion, and there are typically 12 of those. And then lumbar, which is our low back, and there are 5 of those. And then we kind of get into the area of the pelvis and sacrum. And so it's a pretty uniform anatomy. In between the bones of our spine are the discs. And that allows us to sort of absorb the stresses and strains of activity, life, aging, exercise, all those things. But it's also where a lot of our problems come from. As those discs wear down or get injured, that's what really can cause pain or really compress nerves, because in the end, all of these structures are there to help support and protect the nerves in the spinal cord. And a lot of times people can develop, compression or injury of those areas, which might require us to treat.
Right. So speaking of that, is there anybody who is typically affected by neck and back problems, like people of a certain gender or age more susceptible to it? Could you talk a little bit about that?
It's really, all over the place. I mean, it's really anybody can be. We'll see more patients related to age, and that's more of kind of wear and tear of life, degeneration, arthritis. Some of that is genetic. You're kind of predisposed to go that way, and some of that is just that you've led an active life and you pay the price a little bit. That's probably the majority of cases, but there are plenty of younger people, even teenagers into 20s and 30s that will develop a spine issue or a disc herniation problem that might require treatment. I'd say that the majority of those treatments don't require somebody like Dr. Sandro or myself to operate on it. Majority of those things can be treated non-surgically, but that's why we're here for those patients who we have to help more seriously.
Right, exactly. And Dr. Sandhu, Dr. Calantar touched on this a little bit, but what causes spine problems, and what are the symptoms or warning signs people should look out for that, maybe is more a serious issue that they should see a doctor about it rather than just take a couple Advil and sleep it off or whatever?
Yeah, that's a really good question, because there are a host of problems that can affect the spine. I mean, the most common things are things that just happen with normal aging, activity, wear and tear. So simple things like disc herniations that can compress nerves in either the neck, the lumbar spine are very common. And then as people age, they develop bone spurs and collapse of the disc that lead to compression of the nerves, particularly in the lumbar spine, but also in the neck. And then there are a whole host of other problems that can occur, from tumors that spread to the spine and cause compression of the spinal cord or nerves, or collapse of the spinal column, infections that can do the same thing, trauma that, people, if they're in car accidents, falls, that can fracture a bone in their spine and create instability that would compromise the nerves or the spinal cord, and that needs surgical attention. So, some of the real warning signs are pain in either the arm or legs that is severe and doesn't go away, back pain that is, very severe and doesn't go away with, rest or over-the-counter medications. But I think any of those things should really prompt a patient to, seek medical attention.
And then is there anything people can do to prevent spine problems in the first place? Obviously that might not be the case if it's, like you said, a traumatic incident, but is there anything from just, that they can do to prevent spine problems from like wear and tear, that sort of thing?
I think the best thing people can do is, regular exercise, focus on core strengthening. I mean, that really helps protect the back, the spine, and maintaining good strength of your muscles. If they're smokers, to stop smoking, because that's very harmful to the discs in general, as it is to other parts of the body. So, and then control their weight. I mean, being overweight does affect the spine. And I think, really those three things are what we have in our control. The rest is kind of genetic, environmental, that, we can't really control.
Right. And Dr. Calantar, when someone first feels pain, when should they see a doctor? And can you talk a little bit about the diagnosis, the process that they go through, explain the patient journey a little bit?
Sure. I think the most recent data is that low back pain is one of the most common, if not the most common reason a patient in the United States sees a doctor. So these are pretty common things, but really the vast majority of those are short-lived and most likely muscular. So just because you've developed pain in the back or neck, it doesn't necessarily mean you have to immediately see a spine surgeon or even a doctor. Most frequently it's muscular, and especially if you know what set it off, back off of that, modify your activity. That's not necessarily bed rest. It means that you just back off of more of the strenuous type stuff, light stretching. If you're able to take anti-inflammatories, even simply over the counter, like ibuprofen and Motrin, if you have no reason you can't take those, that's probably the first step. Most cases within a week or two, that's subsiding and goes away. And if it persists after that, or despite that, that's probably an indication for you to see a doctor, if not your primary care. Red flags, and Dr. Saylor alluded to this a little bit, is going to be if you're developing pain, numbness, tingling, or sense of weakness in your arms or legs. If it's in your arms, that can very well be because there's compression of a nerve in your neck from a disc herniation, something like that. If it's in your legs, it could be the same thing happening, but in your low back. There are very rare emergency situations in the spine. Despite the fear that people will have there, it's very unlikely, very rare that you develop some severe pressure on the spinal cord that's going to paralyze you or something like that. So that's definitely not something to jump to as your first concern. But of course, if you're feeling weak, or your ability to walk or even use the bathroom is really compromised, that's something you don't want to wait a few weeks to tell somebody about, and you may need to go to the emergency room or something like that. Diagnostically, we only generally have to start to push that envelope if symptoms are persisting outside of that 2, 3, 4, 6 week range, or if we have a concern that there's numbness or weakness that's not getting better. And really our biggest workhorse image is going to be an MRI. That really gives us a better understanding of the anatomy of what's going on, the severity, and whether or not we need to, pick up extra treatment here to resolve the issue.
Right. And how can someone tell the difference between a strained muscle and a disc herniation? Is that easy to tell, or a little difficult?
Sometimes it is, sometimes it's not.
Yeah.
The majority of disc issues and muscle issues both can get better without surgical treatment or much intervention. But the real sort of separator between the two is going to be if it starts to involve a nerve. If you have a big enough disc problem, because of the proximity of the nerves to those discs, it is more likely that you'll start to develop that pain or numbness or tingling or even weakness down an arm or leg. So that's our biggest and most easiest way to distinguish between the two. If it's staying in your back or staying in your neck, it could be muscle, it could be disc, or it could be both. But in the early period, they're sort of treated the same way. Back off of activity, use anti-inflammatories, throw heat at it, throw ice at it, stretch, physical therapy. And in most cases, it takes care of it. But if you start to develop those symptoms down the arms or legs, that is more likely a nerve issue as a result of the disc.
Okay. And so that kind of leads into my next question for Dr. Sandhu. Can surgery be avoided, and what are some other treatment options? I guess maybe, like we said, we've covered the stretching and, just resting for a little bit, but I guess maybe if you have a more serious injury, can surgery still be avoided?
Yeah, often it can. I mean, for common things like disc herniations, stenosis from aging, degenerative processes, a lot of these can be avoided. I mean, 70% of most disc herniations get better on their own without surgical intervention. And generally what's done is people start therapy to strengthen their core muscles. If the pain is really severe, they can have a steroid injection. Usually pain management doctors are the ones that do that, but it delivers steroid medicine right over the nerves, which helps reduce some inflammation, reduce pain, and then help them, get through the physical therapy. And then over time, the discs and can regress and get better. The natural history is it can take sometimes up to 2 years for that disc to really regress completely and get back to baseline. But there are situations where it won't, and pain persists, and I think those are the people that end up getting surgery. Or
once again, leads into my next question that we've
right.
covered a couple times. When is surgery necessary? I think,
Sure.
like I said, we touched on it, but it's an important thing to kind of double back on.
Yes, and I was just going to continue because there are situations where we would offer surgery right away, because if someone, let's say, has a significant weakness or the pain is truly intractable and they're very limited in what they can do, I mean, those are situations where surgery would be done sooner rather than later. But most of the time, people have tried the conservative treatments of therapy, injections, they don't get better, and it really affects their lifestyle in terms of pain, mobility, normal activities. So in those situations, surgery is a great option.
Yeah, well, thank you. And I'm just going to take a second to pause. And if our viewers are just now joining us, thanks for tuning in. I'm joined today by Medstar Health spine surgeons, Dr. Fahim Sandhu and Dr. Bobby Calantar. And we're discussing minimally invasive spine surgery, including topics like the spine's anatomy, when you should see a doctor, what makes surgery necessary, and how to preserve your movement. We've still got a lot more to discuss, so stick around. Give us a like to let us know you're watching. Share this broadcast with your friends. And if you have any questions for our experts, you can ask those in the comments below. So the spine is a big part of our skeleton. I think that's pretty known. What does it mean when a spine surgery is minimally invasive, Dr. Calantar?
So, we really talk about what is the trauma of the surgery itself. So if you look at traditional spine surgery in the low back, for example, it can be fairly traumatic. I mean, we're doing a lot of damage just in the act of doing the surgery, which can affect the recovery process. We have to really manipulate the muscles, move them out of the way, expose the spine so that we can see the structures we need to see to do the surgery. And not to say those aren't successful in many cases, but it can be a tough recovery. There are some increased risks for infection, increased risk for blood loss. Your mobility is affected in those beginning days. So minimally invasive spine surgery, which has really allowed us to change how we look at things and how we treat things based on the way technology has evolved, is a way for us to do those same kinds of surgeries without traumatizing the patients. So sometimes that means it's through very small incisions, kind of like if you were getting your appendix out now, you would do it laparoscopically through a couple of little tiny incisions rather than a bigger one. Sometimes it means that we do it by minimizing how we traumatize that muscle, and we really don't cut the muscle or violate it. We travel through it with different techniques, and in the end, that allows for a patient that can mobilize and get up and move much quicker, less risk of being in bed and forming things like urinary tract infections and pneumonia and things like that. The risk of infection is less. The less we traumatize tissue, the risk of blood loss is less. So there's a lot of different kinds of minimally invasive surgery in spine that we can really apply to the problem now. And that's really been how this complementary training now, as Dr. Sandhu had addressed earlier, between neuro and ortho, is really bringing these two specialties together to really push the envelope with technology development has really allowed us to kind of push that into patient care.
Yeah, that's awesome.
Can
And
I just add one thing, Sarah? I mean, that's a great explanation, Bobby. I would just say to elaborate on that a little bit. I think a lot of what we do is looking toward long-term outcomes for the spine. So minimizing damage to the muscles and ligaments as much as possible. So it preserves long-term function of the spine. So there are ways that we can get to the spine, particularly from the front, whether it's the neck or the lumbar spine. And in those approaches, you really split through the muscles and push normal structures out of the way. And we really don't cut much of anything. And we can do very effective surgery on the spine. And then we haven't touched any of the muscles in the back. And I think that's really important long-term in terms of maintaining good function and health for the spine.
Yeah, great, thank you. And so with that, my next question is, are there any myths around spine surgery? I don't know if this is really a myth, but when I hear spine surgery, like it makes me tingle. It gives me nervous. It sounds, like a huge surgery. Is there any myths? Is there anything, Dr. Calantar, you want to clear up about that while you have the floor?
Yeah. I mean, there's a lot of them out there, I think. But I mean, in the end, understandably, when we're talking about the spine and working around a nerve or working around the spinal cord, I think, there is an inherent concern, risk that comes with that. Am I going to get paralyzed or something like that? And I don't know if this is a myth or not, but in reality, our techniques, our training, our ability to monitor nerve function during surgery has really minimized, if not eliminated, the significant risks that come along with that. I mean, the risk of paralysis from spinal surgery. A lot of people are worried that they're going to wake up and not be able to move their legs or their arms or something like that. And so I think that's probably a blown out of proportion myth that comes along with it. The other one is, when we do fusions, for example, and we're doing them for the right reasons, there's a myth that's tied to the fact that if I get a fusion, I'm guaranteed to get another surgery, or this is just the first of 10 surgeries that I get, or it's gonna make me have more pain, or I'm not gonna be able to return, back to sports and things like that. And in reality, that's not true. And if we're doing these to treat the right kinds of conditions where you have instability or a real need for it, those patients, once they recover, can really go back to a full life, sports, exercise, golf, tennis. And really, it's if you get your back strong, and this alludes to some of the ways we prevent back issues, as Fahim mentioned, where you keep your core strong and keep your weight down. The risk of developing other problems that might need more surgery after you've had a fusion is really minimal these days, and with more modern techniques and these less invasive interventions that we have. So, those are probably the most common two that patients kind of come to me with about what their concerns with spine surgery, and in reality we can get away with it. Another one is a lot of concerns patients have that we're always having to take their, if we're going to do a fusion, or we're going to have to take bone from their hip or somewhere else. And in the majority of cases, we don't need to. Our techniques and our technology with some of the bone graft biologics and synthetic stuff that we have really has eliminated the need for that in most cases. So that's another benefit that we have with where we are.
Awesome, thank you. That's great to hear. We have a couple questions from our viewers about stenosis. John was asking, are there any non-surgical treatments for stenosis? And then Karen was asking what can cause severe stenosis in somebody who is younger, because she said, it seems like I only see this in older generations. So what would cause it in someone who's younger?
Yeah, I mean, I'll jump on that real quickly. I mean, stenosis can come most commonly from degenerative issues. So as you get older, your joints of your spine start to get enlarged, and they can form bone spurs. The ligaments that run around the nerves start to thicken, the discs start to bulge. So that's the most common form. but you can get it younger, and that sometimes can be a more of a genetic predisposition to it. Some people develop that. There's something called congenital stenosis, where you're just born with a little bit less room for the nerves than maybe somebody else, and that might predispose you to get compression of those nerves from more minor disc bulges. But probably the more common reason a younger person gets stenosis is because they've developed a disc herniation or a disc bulge that is compressing those nerves and is creating the symptoms that might come from that. Non-surgically, there are treatments. We generally put patients through, unless they have sort of significant weakness or loss of function that might force us to jump to surgery more quickly. In most cases, for patients with stenosis, we'll begin with some non-surgical treatment, and it goes back to physical therapy to get the core strong, anti-inflammatories to minimize inflammation of those nerves, even injections like epidurals. And in many cases, that's enough to control, calm it down, and allow the patient to live with it. If we just start MRIing people walking around who haven't had any symptoms, eventually we'll find some people who have stenosis and never knew it. So it doesn't always mean you're going to have a problem that needs surgical treatment.
Okay.
Yeah.
Well, thank you for explaining that. Did you have something?
I will add, patients will read online about non-surgical treatments like regenerative medicine, stem cells, intraspinous spacers that are generally done by non-surgical pain specialists. But many of those don't address the root cause of the problem, and especially things like stem cells. I would caution patients to really research that carefully, because a lot of the stem cell research hasn't been validated in large studies, and it's very expensive still. So I think if someone has real stenosis, the best way to treat that, if they've failed all conservative management, is really direct decompression of removing the factor that's causing stenosis, whether it's bone and ligament or the disc that may be present in a younger person.
Okay. Well, thank you both for answering that, and thank you for your questions. We have another question from Karen, who is actually, she's asking one of my questions that I was going to ask on, so we'll just get to it now. Is there anything new on the horizon for lumbar spine issues? Which I was going to ask if there's any, exciting innovations or research or technology that's coming out. Dr. Sandhu, do you want to answer that?
There are newer devices that are coming out that have been very promising. I was involved in the device study for a newer device called TOPS, and it's a motion preserving device that we can treat spinal problems like slippage of the vertebrae and stenosis in older people, but still preserve the motion and not do a fusion. In our clinical trial, the results were actually quite favorable for that device. And I think the other thing that's very exciting is just newer imaging and robotics technology that allows us to more reproducibly and precisely place implants into the spine in a less invasive manner. And then I think in the future, it'll offer more of a procedural solution as well, not just putting in screws, but helping us, direct the decompression and do it in a more reproducible, safe manner.
Awesome, thank you.
Yeah, I'd agree with that completely. I think the technology is really one of the more exciting things that I think is happening in spine. It's really taking off. The robotics, the artificial intelligence, the augmented reality that we can use to perform a safer, faster in many cases, and less traumatic surgery for patients. Where technology might not, this might go back to one of the myth things, but we're not seeing lasers come into spine surgery quite yet, though that's been marketed and advertised in certain situations. That's not a realistic option available to us. We're not using those kinds of things. It's really where the technology we just described is going.
Awesome. Thank you. That sounds great. And thank you for your question, Karen. Um, Going back to minimally invasive surgery, uh, Dr. Sandhu, who would be a candidate for minimally invasive spine surgery?
Really, any patient, as long as the pathology is amenable to treating the problem using minimally invasive techniques. I mean, I've treated young people, 16-year-olds for disc herniation, and it's very helpful to do it less invasively. And then the other end of the spectrum, people, a few people in their 90s that have bad stenosis or in generally good health and still benefit greatly from having a decompression. And you can imagine in an elderly patient doing it through a 2-centimeter skin incision with very little blood loss and faster recovery is a very, important and beneficial thing for them. But everyone can benefit regardless of age. It really comes down to, what the problem is.
Okay, thanks for explaining that. And what types of surgery do you, I'll ask this to you both, do you guys both perform? Dr. Sandhu, if you want to start.
Sure. I mean, I'll just go through the common things that we do because, I treat the whole spine. I mean, whether from the neck all the way down to the tailbone. I mean, we have to address any problem that comes up. But common things are, removing disc herniations, in the neck or the lower back. Sometimes that's associated with needing to fuse or do a disc replacement, especially in the neck, sometimes in the lumbar spine. A lot of times we're just decompressing the spine, taking bone and ligament away to free up the nerves and avoid or treat pain. And then there are other things that we will treat, like tumors, infections that require more extensive surgeries. Sometimes deformity, we'll treat scoliosis or curvatures of the spine that require much more elaborate surgery to place screws and rods and correct the spinal alignment.
Thank you, Dr.
That's a
Calantar.
broad overstroke, but I'm sure Bobby can fill in some of the details.
Yeah, I mean, I thought you summarized it well. It's pretty consistent with my practice, as he and I both know. We, really anything from the base of the skull down to the the pelvis and the tailbone, and the most common or simple ones are going to be the simple herniations that sometimes need to be treated, in the neck, for example, with just a decompression, all the way through a disc replacement or a fusion, all the way to the more complex surgeries like tumor or scoliosis that involve a much more robust treatment from the front of the spine, back of the spine, and we have a lot of experience treating really all that range of conditions, and not everybody has the same problem, and we have a lot of different tools to treat different problems. So it's really on us to be able to match the right tool to the problem we're trying to treat, and not fit it into a pathway that we use on every patient. And that's really important. I think what's great about the Medstar spine surgeons in both neuro and orthopedics is they have been trained pretty extensively on the whole array of what's out there, and we continue to stay on the cutting edge with technology. A lot of us are involved, as Dr. Sandhu mentioned, with some of the IDE and FDA studies that go to develop and approve some of these products for national use. So it really allows us to stay in touch with where we need to be pushing the envelope and where we shouldn't. And that kind of gives us a good experience to be able to apply it to whoever needs it.
Right. That's awesome. Thank you. And my next question, I think we might have mentioned motion preservation before. If not, I'm bringing it up now. Dr. Sandhu, can you talk about that a little bit?
Sure. I think, we mentioned how, preserving the normal function of the spine is very important long-term. We do know that when we fuse the spine, a certain percentage of people will develop changes above and below the fusion. Doesn't mean that you're guaranteed to need another surgery, but we see those changes in up to 30% of people, and maybe 10 to 15% will end up needing some additional surgery. So spine surgeons recognize this, and really 30 years ago or more, they started developing prostheses that could preserve the motion in both the neck and the lumbar spine to help avoid those situations, plus maintain flexibility of the spine, because the spine is a structure that moves, and taking away motion can be problematic long term. So the devices have really gone through several iterations of design, and I think we're fortunate that now there are great devices for both cervical and lumbar motion preservation, and insurance companies recognize it and doing 1 or 2 levels of disc replacement in the neck. It's very common, and now even 1 and 2 levels of motion preservation in the lumbar spine, which is a little trickier just because the patient population is a little more limited or narrower in scope, and there are more factors in determining who's an ideal candidate. But I think these are great options for patients nowadays.
Thank you. And we actually have another question from one of our viewers. John asks, when decompression is referenced, is that a traction table?
Well, I think what we're referencing to is just it's a way to just explain how we remove the compression on a nerve surgically. So decompression is we're talking about a surgical decompression where we remove whatever the structure is that's pushing on that nerve or nerves. Maybe requiring a fusion with it, many cases not. The traction decompression, that's sort of the non-surgical pathway some physical therapists and chiropractors will use, and in many cases those can help people with sort of more chronic back pain issues that don't really require surgical treatment, but that's not necessarily what we're referring to.
Got it. Okay, thank you for clearing that up. So my next question is, what about artificial disc replacement? Sounds a little bionic. Dr. Calantar, can you explain that and talk about that?
Yeah, so just like what Dr. Saylor was saying, is if we can preserve motion in a disc, we're not going to transmit more strain or pressure to the levels above or below it, and maybe minimize the risk of those becoming a problem. And the research has really shown that that is in fact the case. And these are kind of metal and plastic devices that allow continued motion at the levels of surgery. So we're not eliminating range of motion of those levels either. And, they have been around quite some time. The technique has evolved, and the implants have evolved to the point that they're much more predictable and much more long lasting. And so when a patient is a candidate for it, it is becoming the preferred treatment in many cases. Not everybody is a candidate. This really comes down to understanding the alignment of the spine, the stability of the spine, what is the exact problem in the spine that needs treatment, how many levels are involved. But it is really something that if you even look at the community of spine surgeons now versus 10 years ago, it's really become much more of a mainstay and a procedure we do more frequently.
Mm-hmm. And so next, let's talk a little bit about recovery. We've mentioned it before, but I think it's important to go over again. What should patients expect in terms of recovery? I'm sure it varies based on treatment. And then what would be like the long-term outlook for surgical patients? Is there any lifestyle changes they'll need to make afterwards, follow-up appointments, stuff like that? Dr. Calantar, can you talk about the recovery journey?
Yeah, so as I alluded to before, the more minimally invasive surgeries allow for a much more immediate recovery as far as mobility. So in those patients, and many times, they're out of bed the same day, if not the next. They're out of the hospital the next day, if not the same day. They're walking miles a day by a week or two. Really encouraging to do that. If it's just a decompression, so again, just removing nerve impingement, but not needing to do a fusion with bone graft or rods or anything like that, then most of the time by 4 to 6 weeks, we're letting patients kind of get back into their normal life. We'll utilize physical therapy to help build up the muscle if they need that, and then we just let them fly in most cases. And that includes going back to sports and things like that if they ease back into it. Fusions, whether we do them minimally invasively or more traditionally, they can take 6 months, sometimes even longer, to completely bond or fuse so that we can trust that bone will hold. And so for me, in most cases, when a patient's trying to get back to playing things like tennis or golf or go skiing, we give them that amount of time to really determine, has this bonded enough for us to trust it? That doesn't mean they're in bed until that point. A lot of those times patients, again, are up and moving. They're walking immediately, miles a day. Within a month or so, I'll get them on a stationary bike or an elliptical machine. They can begin a lot of forms of exercise and get back into their normal life pretty quickly. It's just, how do we take it to that next level? We follow those patients over time. We'll see them in the initial follow-up just to get through the surgery, usually around 2 weeks, sometimes 6 weeks. And then we check x-rays 3 months, 6 months, even a year later to follow the fusion and determine, has this fused, and are we heading in the right direction in the way that we want? And in most cases, there is not a real disruption to lifestyle. When we're doing much bigger operations for trauma or for scoliosis or for tumor, and those are much more involved, many more levels that need to be fused, then sometimes there are some limits to sort of the high impact, more intense sports that we got to pull back from, just so that we don't create situations that we have to deal with in the future. But in most cases, we really aren't putting a lot of limitations on patients.
That's great to hear. Dr. Sandhu, did you have anything to add? I just threw a bunch of questions at Dr. Calantar, so I don't know if you had something to add or.
Those were great answers. I agree wholeheartely.
Great. Well, thank you. You did great, Dr. Calantar. After I asked, I realized I threw out 4 questions at once. And so my last question for you guys is how we like to end all of our broadcasts. What is the message that you guys want our viewers to take away after watching this broadcast? Dr. Sandhu, I'll start with you.
Sure. Well, I would say one, I would hope patients don't fear spine surgery. We don't do the same surgery that their parents may have had, 30 plus years ago. I think spine surgery today is much safer, less invasive, and we really treat the full gamut of pathology very effectively. And I think surgeons are very well trained now to do microsurgery and use a microscope and whatever it takes to do things safely and effectively to treat spinal disorders. So and I think the other caveat to that is just that when you need spine surgery, it's really helpful and people do well from spine surgery. I think there's always that myth that someone has a friend and they had spine surgery and they're much worse afterwards. And I hope that's a thing of the past. It can happen, but spine surgery done for the right reasons in the right way is extremely helpful for people. So that would be my final words today.
Great, thank you. Dr. Calantar?
Yeah, I think that's well said. Ditto to most of that right there. It is, the takeaway is, spine surgery works. And to use Fahim's words there, if it's done for the right reasons and in the right way, it works. And I think that, what I know of my colleagues at Medstar is that we don't always look to jump to spine surgery the first time you have a problem. And in the majority of cases, we're really going to try to objectively advise you whether or not you should have it. And in most cases, you don't need it. But if you need it, it really is a very powerful way. And we can do this much more safely and much less traumatically and much more predictably for the short and the long term. And I think it just is something that comes with our training, our experience, and how technology has evolved.
Awesome. Well, I think that's a great way to wrap up our broadcast. Thank you both again for joining us today. We really appreciate you all taking time out of your day to be here and answer our questions. And thank you to our viewers for tuning in and asking your questions as well. If you'd like more information or to schedule an appointment with one of our doctors, please call 202-295-0000. 0512. And we'll be posting that phone number in the comments as well. Thanks again, and we will see you next time.
Right. Thank you. Sarah.
Thank you.
Thank you.